My name is Ryan Peterson, and I am the Director of Data Analytics at the Alliance. If you're in this room, it's because you're interested in learning more about data. I am thrilled to be kicking off this afternoon's session because understanding and harnessing the power of data is not just a passion of mine, but it's also critical for driving business success. In fact, the access to information is so critical today that it's been referred to as the oil of the 21st century, and analytics, the combustion engine. In addition, employers are responsible for being good stewards of company resources, and this includes not overpaying for your health care. To make informed decisions about your health plan, it's important to have access to your data and to understand where your health care dollars are spent. Under the Consolidated Appropriations Act, you have the right to access your data. If you do not currently have this access, you need to have a discussion with your TPA. Even after you have this data, it can be overwhelming and difficult to interpret. At the Alliance, we believe so strongly in the power of data that we'll be hosting half-day workshops this summer so you can learn how to leverage your own data. If you like what you hear today and want to learn how to apply this to your own organization, register to attend one of our free summer sessions. More details are available at the Alliance Help Desk in the back of the ballroom with additional information to be sent out via email. We'll be sharing information on the RAND 5.0 study results on price transparency during our June 12th webinar, so save those dates. All right, now to the speaker. And now it's my honor to introduce our special guest speaker, Cora Upsall, Health Fund Director of the 32BJ Health Fund Health Fund Director of the 32BJ Health Fund in New York City. 32BJ is a self-funded plan that provides affordable, comprehensive, and innovative health coverage to 200,000 union members and their families. By knowing her data, Cora was able to implement multiple benefit changes that saved more than $35 million. Changes included removing New York Presbyterian Hospital system and physicians from their network, transitioning to a new pharmacy vendor and pharmacy group purchasing coalition, and establishing an expanded Centers of Excellence program administered by Mount Sinai Solutions. And if that weren't enough, currently she is leading a comprehensive medical RFP. Prior to joining the 32BJ Fund, Cora spent 12 years at Express Scripts as a pharmacy benefit manager, where she held a variety of roles, including those involved with Medicare Part D, strategy and acquisitions, operations, and account management. She holds an MBA from St. Louis University. Please join me in welcoming Cora to stage.
Good afternoon, everyone. I know it's really exciting. Data after lunch. Probably not necessarily the thing you're like, oh yeah, this is what I really want to do. So today we're going to be talking about data for smarter decision making. That's like the fancy title, but mostly I'm going to be geeking out a little bit with you all and talking about what we at the 32BJ Health Fund has done with data and how you can use your data as well. So you all heard a little bit about me from Ryan, and I appreciate that. Missed the best part is that this was like coming home. So I grew up in Minnesota. I went to school in Wisconsin. I graduated from the University of River Falls and spent plenty of time in Wisconsin in my college years. I became a Packer fan because I might have grown up in Minnesota, but when you go to college in Wisconsin, you only have one choice, especially when you date the farmers. Some of you in here know. So it's been fun to come home to Wisconsin. I now live in New York City, about as far from Wisconsin as you can get, as my dad, the hunter and fisher from Minnesota, reminds me every time he comes to visit. But the thing about this is that healthcare and data for healthcare is universal. And so today we're going to walk through a couple of different things. But first I want to build you my credibility, because again, woman from New York is not always the thing that you think of, oh, she's going to understand what we're talking about here. 32BJ Health Fund, we have over 200,000 covered lives. These are the working class folks on the Eastern Seaboard. They are residential and commercial real estate workers, security workers, window washers, door people, airport workers. So the blue-collar folks that make New York City and the Eastern Seaboard run. The fund is a Taft-Hartley benefit fund, which means I'm jointly governed by both employers and the union. And we get contributions from over 5,000 employers toward our benefit. We provide high-quality health benefits with $0 monthly premiums. Healthcare is 100% paid for by the employers. We have no in-network deductibles, and we have low copays. And I say all of that because you're thinking, that sounds really hard to do, and it is. And we do that because we use our data. And so one of the reasons I'm here today is to kind of talk through how you also can use data. I will continue to pitch Ryan's in-person data summits. I highly recommend them because we use our claims data every day. I was at lunch and we were just talking about preventative versus diagnostic colonoscopies, and I sent a note, and my analysts, when I get home tomorrow, I'm going to say, I have a really fun project for you. They don't always agree, but I'm going to try. But we use data in really specific ways. First, it helps us know how we're spending our money. Second, we use it to leverage it for all of our plan decisions. I don't know about any of you, but when you get sold point solutions, it's always just trust me, you're going to save so much money. We've learned that's not always true. And we use it to evaluate our plan designs, ensure that we're continuing to offer the right high-quality benefits. And lastly, we do use outside tools that I'm going to talk a little bit about today. All right, all of that kind of the stuff out of the way. What are we talking about today? Today, we're going to talk about why you need to care about your data. We're going to talk about what the data can show you. We're going to talk about why you need to hire why hiring a healthcare analyst can be extremely beneficial for you, which I know probably for some of you feels overwhelming, because it feels overwhelming to me and I already have them. How you can start to look at your data, and then finally, what outside tools are available. And so I hope by the end of this, you feel a little more comfortable that when you look at your data, you look at the reports you're getting from the Alliance, you can say, okay, now I understand a little bit what I'm going to do with this today. So first, why you should care about the data. This is the baseline information. The first, you're required to. Ryan mentioned it when he started this conversation. The Consolidated Appropriations Act codified the requirement that you have a responsibility to know where your healthcare dollars are being spent. This is the time when I always say, I am not a provider, I'm not a pharmacist, and I am not a lawyer, because this is when it gets to the legally things. And my lawyers make sure I'm very clear. I am not a lawyer, so I'm not giving you any legal advice, but you may have heard lots of conversations about the fiduciary responsibility. That's where this comes into play. So that's one, you're required to care about it. Number two, you have a right to see your data. So I know the Alliance provides you all with data, but before you came to the Alliance, were you getting your claims data? Did you have your health insurance carrier say to you, oh, you don't need to see that, I've got it. You're not allowed to have that. The Consolidated Appropriations Act banned gag clauses in these contracts, which means that your carrier must give you access to your claims data. If you have a wrap network, same concept, you must get access to this data. And three, now you have to care about it, you have the right to see about it, you also have the right to know about data outside of your own. And this is the transparency and coverage mandates that hospitals and payers must post their prices online. It's really fair to say compliance has been mediocre at best, and we'll touch on this at the very tail end. But this is really important because it starts to give you some baseline comparisons to what are you spending, what are other payers spending, and how are you competitive in the marketplace. All right, so we all know healthcare is an ever-increasing cost for all of us in this room. I always put this slide up because this is where we start to talk about how healthcare costs really hit home outside of just the balance sheet. When the union and the employers come together and they look at their healthcare costs over the last 10 years, wages have increased 54%, but healthcare costs have increased 230%. At the same time, healthcare as a percentage of total compensation was 17%, and it's now 37%, which means that for every dollar that is spent on benefits, 37 cents now goes towards healthcare. And so the last piece about that is that we think about what does that really mean to the employee and to you all here, is that this is the real dollars, is that had healthcare grown at the rate of inflation, so if it had equaled the rate of inflation, my members would have had $5,000 more in their pocket in annual wages every year. That's real money. That's grocery money. That's daycare money. That's rent money. And it's being, put into the healthcare pockets of the healthcare system. So we talk about all right, so now let's talk a second about healthcare inflation. If I were to raise, all right, I can't really see you all, but I'm just going to pretend you're going to raise your hand when I ask this question. How many people think if I were to give you the three things that are driving healthcare costs, PBMs, insurance premiums, and hospital prices, how many of you think that PBM costs or pharmacy costs are the number one driver of healthcare costs today? All right, and again, I can't see you, so I'm just pretending you're participating. How many of you think it's health insurance premiums? And then the last one is hospital prices. And I did see some people, I'm so proud. Some people, I could see a few hands. If we look at this, pharmacy, which is the thing, by the way, that we always hear about in the news, in the last 10 years, cumulative rate of inflation for pharmacy costs have been about 30%. Your insurance premiums, which we all feel very acutely in our paychecks, it's about 50%. But hospital prices have gone up over 80% in the last 10 years. And you might say, okay, Cora, well, why do I care? The reason you need to care, I shouldn't have, all right, well, whatever. I was going to not click yet. The reason you need to care is because when you start to look at where you're spending your money, that's what you can start to look at your benefits. Earlier this morning, folks were talking about having on-site and near-site clinics. How do we help get people care that is affordable in the right way? But also, how do we have the person who bypassed the hospital and understood the need to go to the clinic first? Turns out should have probably gone to the hospital. That's okay. But this is why we need to understand this. And so you say, okay, Cora, you've now just told me hospital prices are a problem. You've told me I need to know my data. But that's really overwhelming. I don't know if any of you, I find my EOB overwhelming, let alone healthcare claims data. So one of the things I would say to you all is I would encourage you to hire a healthcare analyst or think about who on your organization maybe could become a healthcare analyst, because these are the folks who can help make the data you have actionable and usable. Healthcare data is complicated, but an analyst can come in and look at it and they'll have experience in using healthcare claims data. They can help you create meaningful visuals that helps you actually understand it. And I'll show you a few examples as we go through. They're going to clean up this messy data because carriers don't make it easy for you to understand your data. I'm assuming the data you get from the Alliance is pristine, though, because they'll be the exception to our rule. Right, Ryan? Absolutely. There you go. But they can also then start to help you look at different questions. What are the things you should be looking at in your data? They can do a wide variety of analyses. It's not just how much did I spend in Q1 versus Q2. And then finally, they can proactively engage the data that can give you as business leaders insight as to where you're going. So, okay, you've hired someone, or maybe you yourself are the experts. You're going to ask yourself, what can I do with the data? My team put this together, my healthcare analytics team, they're great people. And they were like, well, Cora, you really can think about this in 3 different ways. And they created this nice graph for me, which is data 101, 201, and 301. And the important part to note here is that most of what you need done is in data 101. There's absolutely, you can get so much value out of just understanding the who, what, and where of your data. How much you're spending, where are you spending it? Who are your top spenders? Who are the top providers? This is the kind of thing that then gives you information to figure out how do we redirect people to better primary care? But you can't make those decisions if you don't have that data 101. Data 201 is what we're going to call the deep dive. This is how do you get to that next level, the stuff that I personally find really fascinating. Where are you spending over time? How do you figure out what disease state, drug, or health condition or health system is costing you different kinds of money? The ability to really get to that next level. And then the last piece is what we're going to just call healthcare or data 301, which is your more complex data analysis. And I'm going to give you an example of this in a few slides. And it will be busy and it will be complicated, but it is the kind of visuals that a good analyst can do that helps you think about data a little bit outside the box. All right, so hopefully I got through all of the boring parts, and now I will do the parts that I think is a little more fun, which is the actual practical application of data. And then I just realized how geeky I sound by talking about the fun and the practical applications of data. Data 101, where are you spending your money? So we are really big, and we spend approximately $1.5 billion a year in healthcare spend, which seems like a lot, because it is. But we did the math and we said, okay, in 2019, and this data is true for 2022, and actually it looks to be true for 2023, that 44% of the dollars that we spend on healthcare goes to inpatient and outpatient hospital spend. That's the big dark blue section. But the reason I want to put up there the findings from CMS is that it doesn't matter that I am a jumbo 217,000 covered life client, because CMS's data shows that inpatient and outpatient hospital costs account for 44% of the average employer spend as well. 44% are going to hospital, inpatient, and outpatient spend. Okay, great. Now y'all know how much you're spending your dollars, and you're like, okay, great, now what, Cora? So we go to data 201. Here's an example of how we went to that next level. And we were able to look at how much are we paying by procedure at different hospitals. And we looked at colonoscopy. It's like, again, remember, not a doctor. But colonoscopies are a colonoscopy is a colonoscopy. I'm sure there's some clinician out here who's going to explain to me why that's not true. But for the sake of argument, we're just going to go with it. And when we looked at our data in 2021, we found out that at one hospital system, and these are mostly this is all outpatient, I was spending $2,000 for a colonoscopy, and another, the arguably most expensive hospital in New York City, I was spending $10,000 for a colonoscopy. What makes that colonoscopy 5 times more expensive? I don't know. We also looked at hips, because one of the things that you'll hear a lot about is centers of excellence. It's where you will help direct members to the providers that can provide high quality care at a lower price. And we looked at that in 2018 and again in 2019, and implemented a centers of excellence program for hips and knees. And we did that because when we looked at the data, we found that at New York Presbyterian, the most expensive hospital system in New York, we were paying on average $83,000 for a hip replacement. And then when I add in every other hospital, which are other really expensive hospitals in New York, I was still paying about $58,000. And again, I am not a doctor, but a hip replacement, one of the reasons they work really well for centers of excellence is because they can, they're pretty, if you find a good doctor, they can be done. And so it's really important when you start to look at this, it allows you also to see where you're, so now I've figured out that I'm spending all my money at inpatient, outpatient hospitals, and I'm starting to understand that hospitals look a lot different, and every hospital looks different. But this is also why you all have the Alliance. They've done this math. They've done this analysis, and they're finding the providers that can come in and provide high quality care to your members. You've got direct primary care, advanced primary care, a lot of things that will continue to be talked about, has been talked about on the stage and into the future. And I think it's just really important because this is why organizations like the Alliance are so important, because they're taking this data and saying we can do this in a better way. All right, now I warn you about my next slide, which is the 301. I love this slide, but it is very busy. But I always like to show it because it reiterates all of the points we've talked about thus far. What we were able to figure out and what my healthcare analysts were able to do, we were able to create a visual representation of what is driving our trend over the last few years. It's a very busy slide. And what you'll see is everything that's in green are plan changes we made and how that impacted our trend. Everything in blue is claim volume. So you'll see where COVID happened. We had a drop in claim volume. You'll see purple is high cost claims. That salmon peachy color is your case mix. So inpatient, outpatient, high severity, things like low severity. And then we have the bucket of yellow, which is other, which we indicate really represents for us price. And so what this slide shows you is my plan changes don't do a whole lot. Utilization, we can't always control. Case mix, you can do something about. And severity, you can't always control. But in the end, no matter what I do, that yellow bar eats up any savings we can have by a plan change. Prices are that impactful to trend. So what did we do about it? I'm going to kind of end this conversation a little bit, and I really do hope we open it up for some questions and discussion. Is one of the things we did is this is how you can leverage your data, is we removed a large hospital system from our network. In January of 2022, we took out New York Presbyterian Hospital and all of their affiliated physicians from our network. That is not an easy thing to do. It impacted 25,000 people who had used a physician in the last 2 years. So it's not as though this was an easy choice. But the impact was so important because we were not willing to continue to pay prices that were 40% higher than other competitors. We weren't willing to agree to anti-competitive contracting terms where they would have to be in a preferred network. So I think you guys have tier 2 and premier networks where based on a hospital contract with an insurance carrier, they have to be preferred despite being the most expensive. They said if you have a centers of excellence, we have to be in it. These are the types of things that they said, and we said, you know what, we can't do this anymore. It is not a hospital's job to define our benefit structure. And so we removed them, and again, not an easy decision, but in doing so, we have saved $33 million in 2022, and we anticipate that that number will be roughly the same in 2023, and that is because of moving care from a high-cost provider to a lower-cost provider. So in the last 2 years, we maybe have saved $60 million in just moving care from a high cost to a lower cost provider. That led us to having negative 4.5% trend in 2022, and our trend being flat in 2023. All of those numbers are impressive, but here's where I want to talk about how when you make changes like this, you have to bring it back to the people it impacts. In this instance, the employers and the members. Because of this benefit change, which was hard, and it took a lot of energy and a lot of communications with members, but these savings helped resolve the residential and commercial contracts. These are the two largest contracts that the union has. It gave these working class members of New York City and the East Coast the largest raise in contract history and a one-time bonus for the members. We have stories of members saying, because of this bonus, I could go on vacation. Because of this raise, we're able to continue to live in New York City. Sad but true. But I want to say that we didn't just give back to the members, because remember, I had talked about how we have premium-free health care. But it's not as though it's not being paid for. It's just 100% paid for by the employers. So this savings was able to go then say, okay, employers, we're going to give you 2-month premium holiday in 2022 and in 2023, essentially netting premium increases, depending on the employer, to nothing, to flat. And that we now know, because of the way the union contracting works and the collective bargaining works, what the premium increases will be for the next 4 years. So our premiums will not go up more than 3% in 2024 and 2025, and less than 3% in 2026 and 2027. And I don't know about any of you, but I know my friends who have paid premiums, their premiums have all gone up much more than 3%. And I always want to end this conversation here because it shows the practicality of what you can do with your decision, with your data, and how one massive decision, not easy, but how you need to give back to both the employers can get a benefit and the members. Oh, I forgot to add one more slide. I thought I was all coming down to my 10. So I think I then, because I totally forgot about this, I was wrapping it up, but I will say this last piece is that data exists out there. And you can use outside tools to help talk about this. The first is the RAND Corporation, and Ryan mentioned this at the beginning, that there's going to be a webinar, I think he said June 21st, about the RAND 5.0 data that comes out, right? June 12th, sorry, I got 2 and 1s mixed up, June 12th. RAND will tell you what you're paying on percentage of Medicare. RAND puts Wisconsin, I think, at number 3 or 4 as the most expensive places from a hospital pricing perspective. I think New York sits right up there with them. But it gives you a sense of, it just gives you a data point. All 4 of these tools give you data points of where you land in the whole scheme of pricing. There's the SAGE Transparency tool, which partners with RAND. RAND 5.0 and SAGE 2.0 will be announced later in May. But they use the RAND data, they use the NASHB data, which we'll talk about in just a moment. They use CMS cost reports, Turquoise data, Quantros. They've taken all of this and they've wrapped it into a package that allows you to compare hospitals to Medicare and to one another and figure out, are you getting the best deal? Or, on the upside, you can also say, how can you better manage and direct health care? Then you have the NASHB Hospital Cost Calculator. They leverage the CMS Medicare cost reports. I love this tool because one of the things it gives you is the Medicare break-even. I'm not going to say whether or not Medicare is an effective reimbursement model. But I will say it's a really good benchmark. And one of the things I like about the NASHB tool is it'll tell you if the hospital needs to be paid at 500% of Medicare to break even, or 125% of Medicare to break even. And then lastly is Turquoise Health. So if you recall at the beginning, I talked about the federal transparency and coverage data, the hospital prices. Turquoise was one of the first. There are other organizations out now that can aggregate this data. And it gives you what, and I'm going to show an example in just a moment, it gives you a sense to see what is your contracted rate versus what other carriers out there are contracted. All of the reason I bring these tools here is because I think it can also always feel overwhelming to look at data, is that these are all, well, Turquoise is not, but most of these are free ways to get a sense of what's out there. And so I wanted to show you how we used the Turquoise data. This is a very busy slide. You don't actually need to read anything other than to look at the colors. As we looked at our claims data, and we looked at a select group of 3 different hospitals and the select group of DRGs, and we said, what are we paying? And then what does the publicly available data say other people have contracted for these DRGs? If it's red, it means there are better contracts out there than what we are currently paying. If it's green, it means we have the best price. Directionally only. But it was this picture that led us to pushing to do a medical RFP, which should have been done by now, but we are not quite, because it's hard. It's really hard. But it led us to say, we deserve to know more information. And so now I will end this, and we'll open it up to questions, I ended with this quote from Dalai Lama because I think it's really effective when we think about data and healthcare and where we're going as a future, is that the lack of transparency results in distrust and a deep sense of insecurity. There are too many people in this room, in your communities, of your employees, that are foregoing care because they can't afford it, that are in collections because of hospital pricing, because of the cost of health care. And so the more we use data, the more we have transparency into these processes, the better, since we can kind of rebuild healthcare and build back to this kind of trust and faith we have in what's happening. So with that, I'll open up for questions.
Cora, I just want to commend you. I am a big fan of the work that 32BJ has done, and it's bold to take the step that you took with New York Presbyterian. I'm so curious to know what their response has been, or the response of other providers in the market when you demonstrated your seriousness.
It's an excellent question, Cheryl. They have not reached out to us since. Yeah, I know, we're still surprised by it on a regular basis. So this happened in 2022, and we still have not heard from them. And when we look at this, is that New York is a really interesting place, and I hate when I go to conferences and speakers talk about how their city is different than other people's, but I'm going to do that for a moment, so just indulge me. We have 5 academic medical centers, a city hospital system, and a safety net hospital system in New York. So I have 7 places that members can go see doctors, not to mention independent physician practices and ASCs. So I think that because of the large amount of providers, we don't necessarily always have people clamoring on our door to say, how do we avoid being the next New York Presbyterian? But yeah, no, they have not come back to us. I was just picking Ryan's brain in the back because I'm curious about the whole direct contracting thing. Because it's hard, you would know. You would know it's very hard. But I do think that is where, yeah, I don't actually have a good answer to that.
Did part of the, when you locked out New York Presbyterian, did you see though that your utilization was down? Because some people, when you take away their doc, they just don't go anywhere.
So we did, but it actually I don't think has anything to do with New York Presbyterian, because we saw a drop in utilization in general. And from what we can when we talk to other people, is that 2022 saw a drop of utilization for a lot of employers in part because I think it was the rationalization of COVID. So we saw an uptick of utilization in 2021, and then a drop in 2022. So I don't think it was related to New York Presbyterian. We did see more people choose not to go to their ER and instead go across the park, across Central Park, to a different ER. But no, we didn't really see a drop in utilization that we believe is directly impacted by that, I should clarify.
I have a question. You talk about hiring a healthcare analyst, but what about small companies? Are there other resources other than hiring someone?
So I would say, this is Ryan. He works for the Alliance. And I met a nice man earlier today, who I'm now blanking on his name, who does all of the reporting for the Alliance and sends you all reports. So I would say leverage those types of resources. It is hard, but I will say this, and the thing that I say about analysts is that if you hire an analyst, they should be able to find their salary's worth of savings for you within the first year or two of hiring one. And if they can't, I will tell you, I believe you have the wrong analyst, not a superior plan. And it sounds kind of kitschy when I say that, but I do actually believe that because, there should be able to find that. But I would say find some, there are organizations out there that do claims analysis for you, but truly leverage your internal resources, leverage the Alliance. I agree it's not always practical if you're really tiny, but it is that kind of aspirational step.
And I think that we've shown over and over again today, and it's not unique to the Alliance, it's not unique to the 32BJ fund, that there's a huge variation in price for things that are very steerable. And a lot of it is patient education, and it's been shown kind of time and time again that this is the playbook that we can do to make something actionable so that there can be savings realized. And the Alliance is set up to try and provide those tools, and we can certainly supplement. And you guys can come to the data seminars on June 12th to figure out, do I really need to hire someone? Can I just take what the reporting is that's here and learn a little bit? I would encourage you guys all to come to those and to learn more. And those are in July, not June.
So when you're talking about care navigation and steerage, obviously with the play that you did, you basically forced steerage towards other lower cost hospitals. Beyond the lower cost hospitals, and let's say like your current network of hospitals is good, what other steerage or care navigation tactics are you utilizing for your population today to be able to steer towards like those colonoscopies that are, 17,000 versus 10,000 or something?
That's a great question. So we actually started by tiering the network. That was the first thing we did, and we did that, and we tiered really, truly by price because of the quantity of high-quality providers we have. But we had tiers, and we had inpatient hospital for a preferred hospital was a $100 copay, and it's a $1,000 copay for our non-preferred hospitals. And we saw movement. Not as much as we saw when we obviously moved somebody out of network, but we started through a tiered process. We also have a Centers of Excellence program for bariatric and hips and knees. We also personally have a call center where if every time someone gets a surgery scheduled or gets a pre-certification for surgery, they'll get a phone call from my folks, and our call center folks will help guide them to the lower priced facilities if possible and appropriate. And so we do some of that. We don't right now do clinical care navigation, but that is on my roadmap for 25, 26-ish, because I think, similar to we have a $0 primary care. So we have a variety of things out there. Right now I think it's, okay, how do we take that and then tweak them to make them the most effective?
And I think within the Alliance, some of the simplest things that we can do can be very effective, and site of service is incredibly important. So if you can have the service done at a direct primary care facility, get it done there. If you can't get it done there, go to your primary care clinic. If you can't get it done there, get it done at an urgent care clinic. If you can't get it done there and it's a surgery, ASCs are going to be, ambulatory surgery centers are going to be much cheaper than hospitals. If you can't get it done there, hospital outpatient. Finally, if you can't get it done there, hospital inpatient. And so that continuum of just that education of site of service, independent of contract, you almost always have a step in terms of cost at each of those levels, and just educating to the right site of service so that patients are utilizing healthcare efficiently is something that can be done relatively easily with education.
Got another question over here.
Good morning, or good afternoon, I should say, sorry. I know you mentioned you're doing a medical RFP, and that's kind of a broad term. Can you just help us understand kind of what that process involves, what you're looking for, what you're asking for, and are you using an outside firm to help you as part of that process?
Sure, I would love to. It's been 18 months of insert not so pleasant word here. It's been a really long process. So when I say medical RFP, we're looking for an ASO or TPA carrier. I will say we are down to having to select an ASO, staying with our incumbent or going somewhere else. Our incumbent is currently Anthem, in part because with a client of our size, it turns out there is not really a TPA out there who can support us. Give it a couple more years, and I'm hoping that is going to change things that are not carrier-owned TPAs, I should specify. So we have gone through a process with our RFP where we did two things that are a little bit different. One, we did an RFI first with a few non-negotiable things, such as ownership of data, the right to carve New York Presbyterian out. You would not think how many people could not answer yes to that statement, but most. And then we also led with a contract. And so we sent a contract with our request for proposal for the medical carrier and said, we need you to redline this. And so we've spent hundreds of hours with lawyers going back and forth and said, we will not award our carrier RFP until we have a contract that can be signed in an attempt to protect our interests. But I think that we did use an outside firm. We used Locked-In to assist with the structure and analysis portion of the RFP. But we are really fortunate that I have some really brilliant people who work for me and with me. And so we do a lot of that in-house. But I did really enjoy working with Locked-In.
Now we got time for one more. How are we doing time? One more? All right.
Cora, I'm curious to know if you're using quality data or quality measures as part of your steerage or tiering scenario, and if so, what are you using?
I wish is my answer to you, Cheryl. It's like I actually really wish we had. This past summer, my summer project, like the corner of my desk project for the summer, was to understand and learn about quality data. I can tell you I know just as much now as I did at the beginning of summer because I don't feel like a good solid way of looking at it. We have a maternity program where moms can have a baby for their first prenatal copay of $40, and that's it. So they're having a baby for free. And we do use quality data. We use nationally recognized like NTSV, episiotomy numbers and things like that we use for our maternity program. But beyond, and then we require quality data with our centers of excellence to meet certain requirements, and those mostly come from other like nationally recognized sources. But as far as tiering the hospitals, we have not used quality data because I would kind of say, which one? You know, all of the hospitals in New York, you've got one hospital system that clearly games the system because they only report at their entire system, whereas the rest are reporting out at a specific hospital. It's not easy to figure out. If you figured it out, please let me know, and I would happily take any advice from anyone who has figured out quality. But I haven't cracked that egg yet.
It continues to be a challenge for sure. Thank you, Cora, for sharing your insights on this important topic.
Thank you.
And the power of data and reminding us that the impact that data can have on data-driven decision-making and what the impact can be to an organization. So really thank you.